You want me to stay up here?
Yeah. Okay, this is a chance for you to go on the record with some takeaways as we wrap up. So I'm going to ask Andre, why don't you join us as well as a planning committee member? And I'm going to ask you and Nadine if you would offer some of your takeaways. And then we'll ask the crowd. So it's a chance to get a takeaway in the report that will be a product of this workshop. So what do you think is important for us to remember and for us to work on in the future? And probably more importantly, what's important for us to do to make some of these things happen is critical. So with that, why don't I turn it over to you, Andre?
Great, thank you. I'll reiterate some of the things we just talked about. As oftentimes happens in healthcare, following the money is critical, and it's pretty apparent based on research funding and funding for the delivery system that suicide prevention, and in particular suicide prevention in folks with serious mental illness, is grossly underfunded in order to get at the comprehensive approaches that are really needed to meaningfully move the needle.
Goodbye.
Goodbye. I'm very excited that we got to one concrete idea of how to align financing with the desired outcomes, or at least getting at one of the root causes that drives risk for suicide, and that's around bundled payment. I think the more I've kind of been tweeting about it and researching analogs, the more I get more and more optimistic at how doable this would be, especially now, and including the political winds that are blowing right now. I think there's a lot of alignment. The science appears to be there. It's a matter of getting the right people in the room that control the faucets from a policy perspective, the implementers of those dollar flows, whether it's managed care entities or it's providers that could go at risk, and actually implementing the science. And I think it's also really important, another important takeaway here is eliminating stigma is critical. We need to continue to push that forward. I'm really excited when people like Marcus are able to share in a public forum about issues that they've experienced that most people will not talk about publicly, and we have to talk about it publicly. If we don't talk about it publicly, it'll just keep getting stigmatized. And finally, as I've been very fortunate to participate in a handful of these activities with National Academies, this can't just translate into a cute report. We have to do something. If it's pursuing bundles, great. I'm happy to commit my energy, my organization's energy to moving that forward, whether it's pursuing, a outreach to National Governors Association to take up the evidence that already exists, like on those panels. But we have to actually go out and do this stuff. And we may fail, and that's fine, but let's fail fast, fail cheap, fail often. But we got to get out there and we got to do it. Not just talk about it, not just publish it, but get out there and do it.
Well, I shared a number of my thoughts a minute ago, so I'm not going to repeat them, but let me add a couple of different thoughts. I've really been thinking about, why are these worlds so different? Why is the suicide prevention world and the SMI world so different when there's such a huge overlap? And I think about inside myself, I do all this suicide prevention research, and I do all this clinical work with people with serious and persistent mental illness. So I actually have that split inside myself. That got manifested here, and I think we tried to begin to shift more of the discourse about that today, and I think we're going to have to continue to meet and pull in other stakeholders that really represent both worlds more effectively. I think a second thing that's come up in a variety of ways has to do with this issue of what we're teaching people. So most of us do this work because we have some passion. Lots of people shared a story. I had a family member of this. We have some story that got us to this table. But I know certainly in psychology training, when it starts at the beginning, they rule out everybody who's suicidal and everybody who has a serious mental illness. Like that's your clinic rules out all those people because you can't see them yet. Psychiatry does the opposite model, which is You know nothing, but we're going to have you be the doctor for the people with the most serious mental illness. I'm not sure either of those models makes a lot of sense to me. And it seems like we all, and I think this is true for each of the behavioral health professions, and I think we need to begin to think in a different way of how do we really train everybody to be prepared to do this work, to be exposed to this work, not throw people in before they're ready and have the least experience, treat the most serious people with the most serious illness, and on the other hand, not make people afraid, which is what I think psychology does, like that they can't treat those people until they're like way more experienced. And I think we need to really rethink our teaching in all of our professions about this. I really agree that the solution is at it's like a Bronfenbrenner story, essentially, is what we're saying. It's really this ecological model. We need to look at the individual, the family. We haven't talked very much about families here. There's been some mention, but I think we really need to think about the family more in this context. We've had some conversation about the impact of this work on the clinician and the clinical workforce, and I think we need to talk a lot more about this. I know early on in my career I lost a patient to suicide. That's why I'm sitting here today, or one of the reasons. And AFSP had that program at that time where if you were a clinician who had lost a patient to suicide, you could go and tell your story, and senior people met with you. And I went for 8 hours with a psychiatry resident who I had treated the person with at the time, and it was a pivotal experience for us in terms of healing. And I think now what we have are, let's look at the root cause analysis. Let's find out what everybody did wrong. And I think that is extremely problematic and difficult. And then most people say, well, I'm not going to treat anybody who's high risk again. I'm not going through this root cause analysis deal. And so I think we really need to think about the workforce and how much people end up feeling like failures if they've been involved when somebody dies by suicide. And I think we really need to think about that. And then these larger systems and the payment issues and the communities, that the communities really are, as somebody once said, it takes a village. And I think for these issues, it takes many people in the village. We've also talked about culture some, and some people have talked about it. I feel like we just need to infuse that in this entire conversation. And I'm talking about culture defined broadly, but I think whether we're talking about cultural adaptations to interventions or we're talking about interventions that emerge from a particular cultural group and are not designed to be adapted or generalized, but they're designed specific for that group. But same with assessments and same with prevention efforts, that we really need to have everything we do focus on culture. I have to say that, as probably everyone in here knows, Fred Fries died just recently. And I think of him as a wonderful model of somebody who really brought lived experience to the table. And I think we've had a couple of other people at this discussion with that, but I bet there's lots of other people in this room with lived experience who haven't shared that experience. And so we often have people with lived experience at our tables, but we don't even know about them, because it doesn't even feel safe in a community like this, which happens at every professional meeting I'm at, and that people don't really still feel safe to share their stories. And so I think that has to be part of the change we make too, so that we always create spaces where it's safe enough, where people can feel brave enough to share their story, so we don't have two identified people who have lived experience and then everyone else in the room doesn't have. Talking about binary, that's a continuum too, just like suicidality is a continuum, and we all live on that continuum somewhere.
Okay, thank you to both of you. Just a couple of comments I would add. The last panel was a great example of doing the right thing, and I can tell you, as someone that runs a large organization, doing the right thing works. And one of the great things is it's usually profitable. And people will always argue against doing the right thing, even when there's clear evidence of it. It's interesting when you talk about education, clinical delivery, and systems integration, there is clear evidence of what we need to do to educate clinicians, no question about it. There's clear evidence of what we need to do on clinical delivery, and there's clear evidence of what we need to do on systems integration. And we just need to do the right thing and just do that and really talk about what do we need to do politically to make that happen. Part of my concern is I think the political agenda is embedded in shame and stigma, not just among the population, but among clinicians. And I don't think we advocate enough for this. Part of what I've been encouraged by is I haven't heard people say that this is just too complex a problem. Haven't heard that in the last 2 days. Every time I hear someone tell me this is a complex problem, I know that they're ashamed of the problem, because saying it's too complex means we'll never solve it. We're not accountable for it. We're not responsible for it. And as a result, we don't know what to do. We clearly know what to do across all three of these domains. We have good foundational places to start. We just need to start implementing. I think the bundle is a great place to start. Around well-proven interventions that have been demonstrated to have effect and have been demonstrated to be able to impact a broader base problem. So I'm encouraged by that, and I'm frankly very encouraged by the last couple of days. Now is an opportunity for you to add a takeaway to this, and so I'd welcome you to come up to the mics and let's hear your thoughts and get those recorded before we wrap up.
Thank you. Lisa Jordan, nursing. I want to say that it's been a very powerful day and a half. In terms of my perception and being a nurse and recognizing that we try to teach our students 24/7 care, responsibility. It was really heartening to see the words caring and social determinants and anecdotal information where so many times that's pushed away and not seen as important, but the lived experience really is. And while nursing may not be there to treat, at the basic level, they're there to educate, and we need to be at the table. The issue of caring is one that we've got a great deal of theory on. Our nursing history shows some of the first community health workers being nurses and putting together a caring theory that incorporated patients into the plan of care. And it just a real quick, in the 70s, I worked cancer nursing. I hear you all, many people have friends that have committed suicide. I don't think we take care of ourselves when we have a powerful peer who ends their life. More often than not, it's pushed away. We don't even get to actually process it. So talk about stigma. In the 70s, if you had cancer, you were stigmatized. It's just an easy comment to say, and I mentioned it in our group, but this brought back to mind a woman who had a son in the high school where I had a son, and she was dying of cancer, and she was probably the most powerful person that I have ever met. She was dying, but that was her next growth and developmental stage. I mean, she took it on. She was not allowed to speak to people who had cancer in therapy groups because she was a failure because she had cancer. A person that had the lived experience and grabbed it and said, my kids are going to know all of this kind of information. It was just pushed aside. She was literally dehumanized because of her cancer, where she could talk to people and give them hope. So this is kind of nursing talk, and I apologize for taking time, but we've got to be there with you because we believe as nurses that we're the conduit to get many of the other professionals that are working with a patient together and keep everybody abreast. And just remember us. Thank you.
So, with all due respect, I disagree with you. I don't think nurses don't treat. I think nurses treat in my inpatient unit 24 hours a day. And they are often the people that people in the most trouble turn to for caring and compassion.
You're not disagreeing.
And
you're actually not disagreeing with me.
And so I think we all, I think the issue is for this to be effective, this has to be an interprofessional endeavor. It has to be.
We're in agreement. The word treat has a lot of emotional levels to it. If you're talking about attentive listening, that's treat.
Hi, Scott from the National Association for Behavioral Healthcare. So the part of this is about serious mental illness and mortality rates and people dying by suicide. And if you look at schizophrenia, major depression, bipolar, those individuals die by suicide at a higher rate than the general population. But if you take a step back from that, and this has come up a couple times in conversations I've had in the last 2 days, what is killing people with serious mental illness at a greater rate is physical health conditions, right? That these individuals are dying 25 years sooner than everybody else in the population. They've been left out of this sort of longevity revolution where you're extending life expectancies for all these other conditions. And I think if we're interested in this, I think that's something that we need to think about going forward. And it's not directly related to this, but I think it's part of that greater conversation about serious mental illness and mortality.
Arthur Evans from the American Psychological Association. So first thing I want to do is just commit my organization to these efforts. And so whatever comes out of this, I agree. I think having a great conversation on a report is one thing. What are we going to do next is what is really important. And so I want to commit APA to doing that. We have a lot of members, like some are on your panel, who are experts in this area who I think can be very helpful. The other thing is, I think that for me, it's really important for us to think about this whole conversation. And I really like the work that's happened around zero suicide and the focus on clinical care. And I also believe, though, that we really have to expand out. And so one of the things that I hope we do is to think about how we make sure that every community has someone who takes that on. Providers aren't going to take that on. It really is going to have to be people in government, people who are systems administrators. And frankly, they don't think that way. They think about a very narrow population. And if we think about the kinds of things that we heard Marcus talk about and others talk about, social determinants and where people actually are, we have to get an impact on those places. But it's going to take leadership. And I think one of the things we need to pay attention to is how do we make sure that every community has that kind of leader, even as we're talking about the clinical interventions within our treatment settings.
Jim Allen, University of Minnesota. My quick takeaway is I'd like to again to expand the conversation. We've talked a lot about collaborative care models and integrated care, and I think there's something we can learn from this planning as well. And I'd like to talk just a moment about research. And I think SAMHSA's effort, if it could be aligned with NIH, to actually study the implementation of these ideas. I mean, this suicide is going up off the charts. It's a public public health crisis. And in collaboration with NIH, there's some very important and actually scientifically interesting issues to take on as we study suicide. The issue of this is a low base rate phenomenon, in some ways impossible to study statistically, is true only if we look at death by suicide. But there are so many distal indicators of effective prevention and treatment approaches. We know these things. We need to innovate in our methods. And there's a lot of fascinating work coming out of engineering and process engineering in terms of studying the implementation of our ideas. So it's a ripe time for us to collaborate as well, as we're talking about collaborative teams working together clinically. Thank you.
Hi, Amy Loudermilk from the Suicide Prevention Resource Center. I just wanted to echo Andre's comments and a few others that there is a piece about states that we need to take away from this. And building on what was said here, the Suicide Prevention Resource Center is working on recommendations around state infrastructure for suicide prevention. It's a project that we're working on now. I think that combined with the Action Alliance's recommendations for standard care, and then this piece about maybe going to the National Governors Association or something like that, I think it's time that this issue is elevated, and I can see how it's so multidisciplinary that I hope that would be some kind of a recommendation that we take away, is to do work around states.
So briefly on that, the National Association of State Medicaid Directors annual conference is coming up in a month and a half. I think they're concluding their programming planning, but this might be an interesting opportunity to take these outputs and propose to NAMD that there may be some working sessions there. Also, NASHP does a lot of work that guides states that might be really helpful.
Any additional comments? Richard?
Yeah, so a couple of things. One, I think has to do with one thing that we didn't talk about too much. It was one of the areas that was listed when we thought we might have 7 or 8 groups, which is really about outcomes and tracking of outcomes. And of course, from a research perspective, deaths is hard. And one of the reasons that we have such a robust armamentarium of psychotherapies that have been shown to be effective is that it's used suicide attempts as an outcome variable. So I think that's important. But I also think it's important in terms of healthcare systems tracking the people that they're losing. Part of the reason that the Veterans Administration and the Department of Defense have had such a significant focus on suicide prevention is that they have the data about the people that they're losing, and that leads to an increased focus on accountability. Now, one of the issues, of course, is the delay in mortality statistics. But Michael Schoenbaum, who was here yesterday, not here today, has been doing work, and this is actually a recommendation that's in the ISMIC, the Interdepartmental Serious Mental Illness Coordinating Committee report, which is really about getting information more quickly about really the ultimate outcome issue, which is whether the person is still alive. And one of the issues is that we end up waiting to know whether the death is a suicide, whether it was an accident, an opioid overdose, or whether it was a death from natural causes. However, I think one can make the case that if somebody dies, that really warrants our attention. And we can try to look into finding out how many were accidental overdose, how many were suicide, how many were natural causes, in terms of what we can do. But that there is the potential for more of a real-time response by looking at whether somebody survived overall mortality, and that information potentially can be made available more quickly than the 2-year wait for the CDC statistics that specify the suicides. So that's one thing we didn't get to talk about, but I think is an important area. A couple other things that I'm taking away. First of all, Art, thank you for your comments about APA's interest in continuing to work on these issues, and Andre, your willingness to work on the bundled payment issue. Those are things that SAMHSA can certainly continue to work on in coordination with you and other federal partners. And then also the recommendation regarding technical assistance is something that we can certainly take a look at, which is what is the best way for SAMHSA to make use of our array of technical assistance resources, including the Suicide Prevention Resource Center, but not limited to that. And as people mentioned, that there are a new group of regionally based TA centers that are just starting up. And so having conversations about what their role should be in some of these areas, I think is something that, certainly makes a lot of sense. So anyway, those are the things that I want to mention. I think this link between suicide and serious mental illness on the one hand, and as well as serious emotional disturbance among youth, will be an abiding concern for SAMHSA over the next number of years, because they're both priority areas. It's enshrined in law in the Cures Act. And I think we need to be able to have more of these conversations. And Nadine, thank you for your role in helping to deepen that link in our conversations today. I think we've come to a very a good place through these discussions with some innovative and potentially really important ideas. So thanks.
Can I make a really quick comment? So you alluded there to data and getting some upstream data to look at other outcome variables. I know Dr. V is here. Thank you for coming. But I've brought this up to her, to OASH. CMCS has one of the largest, if not the largest, treasure trove of data, which is all of the claims up to date, only 1 month lagging behind from every single state and territory in the country through the TMSA system. The current leadership is very open, or at least saying that she's open to getting that data out there and usable. We just actually have to go access that data, and at the very least start with academics, or maybe even just interdepartmentally giving that data to CDC, SAMHSA, and others so that we can cross-pollinate different data sources and look at other input or output variables. I think TMSIS, that data set, could address a lot of our methodologic challenges with low incident or low prevalence outcome variables. So for the Transformed Medicaid Statistical Information System, TMSIS.
Well, let me say thank you to everyone for participating. Thanks to the staff that has supported the effort, all of our committee members, the panelists, and the moderators. In particular, to say thank you, Bridget, for doing a great job. Really, really appreciate it, and wish you safe travels back home.